Good morning, everyone, and welcome to the Health Services Research Association webinar series. Before we get underway, I'd like to acknowledge the traditional owners of Australia. For me, based in Sydney, that's the Gadigal people of the Eora Nation, and pay my respects to elders past, present and emerging. The Health Services Research Association is the peak professional body for people doing, planning and funding health services research, and contains a multiple of disciplines. We're very lucky and privileged today to have one of our webinar speakers who won the Best PhD Paper Award. So I'd like to introduce Dr. Sameera Senanayake. Sameera Senanayake is a health economist. He's based at the Australian Centre for Health Services Innovation at the Queensland University of Technology and began his career as a doctor in Sri Lanka before completing his Masters and Doctor of Medicine degrees in public health. He then completed a PhD in health economics from QUT. This was a very productive PhD, produced 7 publications, and he synthesised evidence that can assist decision-making concerning the most efficient use of donor kidneys. Sameera has over 10 years of experience as a public health expert and has been involved in numerous health service research studies over the last few years. His specific research interests are in chronic kidney disease, decision analytic modelling, and predictive analytics. So the way this webinar, will work is Sameera is going to give a presentation that will go for about 30 to 35 minutes. And then we'd ask you as the participant audience to type your questions into the Q&A function button at the bottom of your Zoom screen. So please don't use the chat as that can distract the speaker. Please use the Q&A button, and then I'm going to read out those questions or comments, and Sameera will get a chance to speak to them. So without further ado, one other announcement, a reminder that the conference for the Health Services Research Association is on this year. It'll be in Sydney in December, and the abstracts have opened for the conference and they'll be closing on the 6th of June. Okay, so now without any further ado, I'm going to introduce our speaker, who is going to address the topic, Value for Money in Kidney Transplant Decision-Making, Economic Evaluations of Contemporary Practices. Thank you very much, Sameera.
Thanks, Rachel. Good morning, everyone. Thank you very much for inviting me to deliver this talk. My talk is on value for money in kidney transplant decision-making. This is a brief outline of my presentation today. My presentation is about answering these 3 research questions. Is it cost effective to transplant low quality kidneys? Does the choice of modeling technique have any impact on the cost effectiveness of transplanting low quality kidneys? And what could be the most cost effective kidney allocation system for Australia? And I'll be talking about these in more detail during the presentation. Kidneys are vital for our survival, and many diseases can affect them. And out of those diseases, chronic kidney disease is the abnormalities of kidney structure and function present for more than 3 months with implications to health. And it is a known disease since ancient times. The Hippocratic aphorisms include a certain maxim which may be thought of as referring to CKD. The global burden of CKD is rising. The burden has risen by 8% each year. And approximately 10% of Australians aged 18 years and over have evidence of CKD. And in 2016, diseases of the kidney and urinary tract was the 10th leading cause of deaths in Australia, which accounted for nearly 14% of total deaths. And nearly 20% of the Aboriginal and Torres Strait Islander people aged more than 18 years have evidence of CKD. Chronic kidney disease can be classified based on different classifications, but the classification based on glomerular filtration rate, or GFR, is the most commonly used classification method. The normal GFR of an adult is around 125, and based on the GFR value, CKD can be classified into 6 stages. And if a patient is in stage 5, that is when the GFR is less than 15, the kidneys cannot effectively function and the body requirement exceeds the functional capacity of the kidney. And at this stage, patients need renal replacement therapy. So what are the renal replacement therapies available? It can be either dialysis or transplantation. Dialysis can be hemodialysis or peritoneal dialysis. Hemodialysis is the most common dialysis method world over. And in Australia, 82% of dialysis patients are on hemodialysis. And the balance 18% of dialysis patients are on peritoneal dialysis. And kidney transplant offers best chance of long-term survival and complete rehabilitation. And kidney grafts may be taken from a cadaver or from a living donor. And during 2018, there were more than 1,100 successful kidney transplants performed in Australia, with live donor kidney transplants contributing to 21%. The incidence of patients requiring renal replacement therapy is increasing in Australia, as you can see in the graph. And according to Australia and New Zealand Dialysis and Transplant Registry, which is commonly known as AusHSI, in 2019, there were more than 3,000 patients started on renal replacement therapy. And there were nearly 27,000 patients who were receiving renal replacement therapy. And you can see that the prevalence of renal replacement therapy in Australia is higher than the prevalence seen in Latin America and in Europe. Renal replacement therapy is a huge cost burden as well. According to the New South Wales dialysis costing study, which was done in 2008, annual per patient cost for in-center hemodialysis is nearly $95,000. And home dialysis, it's about $59,000. And the annual per transplant patient cost for live donor kidney transplant is nearly $120,000. And deceased donor, it's about $104,000. That is for the first year. And in follow-up years, for follow-up management, in subsequent years, it's about $14,000. And in 2012, the total cost for CKD was $4.1 billion, which was nearly 3% of the total health expenditure. And in Australia, the direct healthcare cost due to renal replacement therapy in 2009 was $1 billion. And at that time, it was projected that this will increase to $2 billion in 2020. So in summary, the epidemiological burden and financial burden of CKD is rising in Australia. So when a patient is in end-stage renal disease, that is when their kidneys have completely failed, and if the patient is suitable to undergo kidney transplantation, the patient will be waitlisted, which means now the patient is waiting for a suitable kidney donor. In the USA alone, there are more than 100,000 patients waiting for kidneys, in the waiting list. However, only 100,000 kidney transplants are performed globally in a year, which means there's a huge shortage of donor kidneys world over. And also, out of the patients who are in end-stage renal disease, only 25% of the patients will ever be waitlisted, which means 75% of the patients who are in end-stage renal disease, who have completely failed their kidneys, who have to rely on dialysis to sustain their life, will never be considered for a kidney transplantation. And it is common knowledge among the kidney community that if there were no shortage of donor kidneys, most of the patients in end-stage renal disease would be waitlisted and would ultimately receive a kidney. So there are a couple of solutions coming up. Synthetic organs through stem cell generation and 3D printing of kidneys are a couple of such solutions. However, all these solutions still have a long way to go. So what could be the solutions that we can practice at the moment? And these are two of such solutions. First one is increasing the kidney donor pool, and then longevity matching during kidney allocation. And my presentation is based on finding out cost-effective methods to answer these options. Regarding increasing the kidney donor pool, not all donor kidneys can be transplanted. And deceased donor kidneys are graded according to their quality. And due to the shortage of donor kidneys, the suitability criteria of a donor kidney has been expanded so that even low quality kidneys are now being transplanted. And this has increased the donor pool, and which has resulted in increasing number of kidney transplants being performed. Also, it has reduced the mortality associated with continuing dialysis. A successful low quality kidney transplantation transforms a patient who is fully dependent on dialysis, who has to undergo dialysis 3 or 4 times a week, to an almost normal individual. However, these low quality kidney transplants are increasingly associated with graft failure and primary renal allograft dysfunction, which means they are increasingly associated with increased short-term costs, return to dialysis, and post-transplantation expenses. And evidence indicate that due to the greater likelihood of short-term costs associated with low-quality kidney transplants, health systems are reluctant to increase those transplants due to an assumption that they may threaten the overall economic viability of transplant programs. This graph shows the discard rates of donor kidneys according to quality levels. The green line indicates the discard rates of low quality kidneys. And you can see that more than 50% of the low quality kidneys are discarded. And evidence indicate that 50% of the discarded kidneys could have been used to improve the lives of thousands of patients who are on dialysis. So from a health economics perspective, there are 2 competing scenarios. The first scenario, cost and health outcomes of lack of donor kidneys and morbidity and mortality associated with continuing dialysis. In the second scenario, cost and health outcomes of transplanting low quality kidneys and its associated complications. So it would be interesting to know at what level of the quality of donor kidney does it become advantageous to adopt transplant over dialysis. And lack of evidence on the long-term cost effectiveness of transplanting low quality kidneys compared to remaining on dialysis hinders informed decision making by transplant stakeholders. So this brings to the first 2 research questions of my presentation today. Is it cost effective to transplant low quality kidneys? And to answer this, I reviewed the literature systematically to find evidence about the cost effectiveness of transplanting low quality kidneys. I reviewed several databases using appropriate search terms, and I found that only 1 publication assessed the cost effectiveness of transplanting low quality kidney compared to waiting on dialysis. And they found that low quality deceased donor transplants were cost effective compared to remaining on dialysis. However, there were certain limitations of the available evidence. The study did not assess for parameter uncertainty and did not assess the cost effectiveness of transplanting donor organs of differing quality levels. And most importantly, there was no evidence on the relative merits of transplanting a low quality kidney versus remaining on a wait list until a superior quality kidney becomes available, which means when a patient is in a waiting list and if the patient is offered a low quality kidney, both the patients and the physician have to make a decision whether to accept this or reject this. So if they accept it, they have to bear in mind all the possible negative consequences. Because as I said, low quality kidney transplants are increasingly associated with graft failure and other complications. So if they reject it, they reject assuming that they will get a better offer in the future. But due to the scarcity of donor kidneys, this better offer might come in 1 year's time or in 2 years' time, or in certain instances, they might not get a better offer during their lifetime. So this is a very important decision that both the patients and the physicians have to make when they are offered with a low quality kidney. And this information was not available in the literature. And to bridge the knowledge gap, I did an economic evaluation to answer the first research question. And it had 3 aims, and I'll be discussing these aims in my subsequent slides. Quality of a deceased donor kidney is assessed using an index called Kidney Donor Profile Index, which ranges from 0 to 100, with lower values indicating higher quality and higher values indicating lower quality. For the analysis, I divided the KDPI index into 4 quality bands: less than 25, 25 to 49, 50, 74, and more than 74, with less than 25 indicating the highest quality and more than 74 indicating the lowest quality. So the first aim was to assess the cost effectiveness of transplanting deceased donor kidneys of differing quality levels. For example, here in option 1, the patient undergoes the highest quality kidney. In option 2, patient undergoes the lowest quality kidney. And the cost effectiveness of each of the quality bands were compared with each other. Like, for example, less than 25 was compared with more than 74, or less than 25 compared with 25 to 49. Likewise, each of the quality bands were compared with each other. And for this, I used a Markov model which had 4 health states. And in both these options, patients start in the kidney transplant health state. If the kidney transplantation is successful, they will continue to be on this health state, or else the kidney can fail, so that they will move to post-graft failure dialysis health state, which is marked in red, and they will continue to be in this health state while on dialysis. Or they can die after a kidney transplantation, which is marked in blue. And those who fail their grafts will continue to be on this health state while on dialysis, or a certain proportion will undergo retransplantation, or else they can die while on dialysis. And those who undergo retransplantation, if the retransplantation is successful, they will continue to be in this health state, or they can die. And we assume that after retransplantation, the grafts do not fail. So this is an assumption that we made in the analysis. The second aim was to assess the cost effectiveness of transplanting low quality kidneys compared to remaining on the waiting list. For the option 1, we used the same Markov model that was used in the aim 1, where the patient undergoes a kidney of any quality. And in option 2, the patient is waitlisted for a kidney while on dialysis. And this option 2 had 2 health states: waitlisted for a kidney and death. The aim 3 was to assess the cost effectiveness of remaining on the wait list until a high quality kidney becomes available, compared to transplanting a low quality kidney without waiting. Here in option 1, patient is offered a low quality kidney and straight away undergoes transplantation without waiting. But in option 2, patients start in the waiting list health state and continue to be in this health state while on dialysis until they get a superior quality kidney. So compared to option 1, option 2 has an additional health state where they start on waitlisted health state. The cost utility model needed 3 model parameters: transition probabilities, cost, and quality of life or utility values. The transition probabilities were calculated using the data provided from Australia and New Zealand Dialysis and Transplant Registry. And the transition probabilities were extracted from 2 data sets: patients who underwent a deceased donor kidney transplant between 2007 to 2017, which included more than 7,000 patient records, and patients who started dialysis on any modality between 2007 to 2016, which had more than 30,000 patient records. And as per the natural progression of events, the probabilities were considered time-dependent transition probabilities. And I used parametric survival models to calculate the transition probabilities. More specifically, Weibull regression model was used based on its statistical and visual visual fit to the observed data. The costing data were based on 2 Australian national costing studies: the economic impact of end-stage kidney disease in Australia, projections to 2020 by Kidney Health Australia, which was done in 2010, and New South Wales dialysis costing study, which was done in 2008. The transplant costs included cost components such as surgery and hospitalization, immunosuppressive therapy, specialist review and consultations, drugs, and donor costs. And for the first year, the cost was nearly $100,000, and for subsequent years, it was nearly $14,000. The dialysis cost included both procedural and non-procedural costs. The procedural costs included components such as salaries, dialysis fluid, consumables, and depreciation costs. The non-procedural costs included components such as pharmacy, pathology, and medical cost. So the dialysis cost for a patient for a year was nearly $82,000. And peer-reviewed research was used as the source of data for the utility values needed for the Markov model. And the final model was run based on a simulated cohort of 1,000 patients on a 20-year time horizon with a discount rate of 5%. And willingness to pay threshold was $28,000. The perspective was healthcare payer. And a probabilistic sensitivity analysis was used to address the parameter uncertainty. The net monetary benefit was used to summarize the PSA results and compare the value of different interventions. So which means highest net monetary benefit indicates the most cost-effective decision, and choosing anything else would incur an opportunity cost. So regarding the results of the AIM-1, that is cost effectiveness of transplanting deceased donor kidneys of differing quality levels, transplanting the best quality kidney had the highest net monetary benefit, and transplanting the lowest quality kidney had the lowest net monetary benefit, which means transplanting the best quality kidney is the most cost-effective treatment method compared to other KDPI quality bands. And also it was interesting to note that when you take the highest quality kidney, the highest net monetary benefit was when they are transplanted to younger patients. And when you take the lowest quality kidney, it was the highest net monetary benefit was when they are transplanted to older patients. This was an interesting finding that we found in the analysis. So the aim 2 was to assess the cost effectiveness of transplanting low quality kidney compared to remaining on the waiting list. We found that transplanting even the lowest quality kidney is cost effective compared to remaining on wait list while on dialysis. And the aim 3, remaining on the wait list until a high quality kidney becomes available compared to transplanting a low quality kidney without waiting. And we found that transplanting the lowest quality kidney without waiting is the most cost-effective treatment method compared to remaining in the waiting list until a superior quality kidney becomes available. And we did this analysis for different blood groups because availability of donor kidney depends on the blood group of the recipient. And we found that the result was true for all the blood groups. So in summary, from the healthcare payer's perspective, transplanting a higher quality kidney is cost effective compared to lower quality kidney. And transplanting a kidney of any quality is the most cost effective treatment pathway compared to remaining on a wait list and continuing dialysis. And there's a net monetary benefit of transplanting higher quality kidneys to younger patients and lower quality kidneys to older patients. And waiting on dialysis in hopes of receiving a good quality kidney is not a cost-effective strategy at any age group. Therefore, efforts should be made by the health systems to reduce the discard rates of low-quality kidneys with the view of increasing the transplant rates. Then the second research question of the talk of my presentation today. Does the choice of modeling technique have any impact on the cost effectiveness of transplanting low quality kidneys? Economic evaluation of health interventions lends itself to the decision analytic approach using models such as decision trees, Markov models, and discrete event simulation models. The choice among these models is a critical step in the process. And model selection is context specific, with inappropriate models yielding results that could be flawed. So for the second research question, I assessed whether the choice of the modeling method, whether it's Markov or discrete event simulation model, has any impact on the decision to transplant low quality kidneys compared to remaining on dialysis. Discrete event simulation models use patient level simulations, whereas Markov models mostly use cohort level simulations. And these models factor in random timing of events by modeling distributions for patient level time to event information. And but in Markov models, they assume events occur at regular intervals, therefore use same transition probabilities for all patients in the same health state at a particular cycle length. So this was the models that were used for the analysis. The kidney transplant health option had 3 health states, while the dialysis option had 2 health states. And I developed 4 Markov models based on different cycle lengths and different time horizons. Cycle lengths were half-an-year cycle lengths and 1-year cycle lengths. And time horizon was 5 years and 20 years. So basically, I compared the results of the DES model with four Markov models, 4 different Markov models based on different cycle lengths and different time horizons. And cost and utility values were same as previous analysis. The transition probabilities were calculated from the same data set. For the Markov model, time-dependent transition probabilities were calculated. And for DES model, time to event information was calculated. And I used parametric survival models to calculate these parameters. And I checked assessed the suitability of 4 parametric survival models: exponential, Weibull, log logistic, and log normal, and found that Weibull regression model fits well to the data. Willingness to pay threshold, the perspective, and the probabilistic sensitivity analysis were same as in the previous analysis. And I found that irrespective of the modeling method, irrespective of the time horizon, or irrespective of the cycle length, transplanting a low quality kidney is the most cost-effective treatment method compared to waiting in the waiting list, waiting for a donor kidney. And I also calculated the incremental net monetary benefit, and I found that the results of the DES model is very much similar to the results of the Markov model, when the Markov model uses shorter cycle lengths and longer time horizons. The difference was only about 5%. But when you consider the Markov models with longer cycle lengths and shorter time horizons, the difference was as high as 30%. So in summary, different modeling methods are unlikely to influence the decision to accept a lower quality kidney transplant or remain waitlisted on dialysis. Both Markov models and DES produce similar results when time-dependent transition probabilities are used, most notable with shorter cycle lengths and longer time horizons. So based on the results of research question 1 and research question 2, we can confidently say that transplanting a low quality kidney, from the healthcare payer's perspective, transplanting a lower quality kidney is the most cost-effective treatment method compared to remaining on dialysis. Then comes to the second solution for scarcity of donor kidney: longevity matching during donor kidney allocation. So when a donor kidney is available, the transplant community has to make a decision as to whom this kidney is going to be transplanted, because there are a lot of potential recipients who are waiting for for donor kidneys. And kidney allocation systems are there in health systems to make these decisions. And kidney allocation is an important aspect to consider in efficient use of this scarce resource. So these are a couple of examples of inappropriate kidney allocation. When a potentially long surviving kidney is transplanted to a potentially short surviving patient. So what happens is the patient is going to die with a functioning graft, which means we'll be wasting graft life years. Also, if we transplant a potentially short surviving kidney to a potentially long surviving patient, what happens is the graft is going to fail when the patient is alive, which means the patient will have to go back to dialysis, or if the patient is lucky enough, the patient will be waitlisted again for a retransplantation. So increased possibility of graft failure while the patient is alive, and increased possibility of patient dying while the graft is still functioning. And both these scenarios represent inefficiency in donor kidney use. And health systems have devised various kidney allocation processes for efficient use of donor kidneys. And longevity matching is one such strategy where we match the graft survival with patient survival. So in longevity matching, what we do is we transplant potentially short surviving kidneys to potentially short surviving patients and long surviving kidneys to long surviving patients. And this maximizes graft life years. And evidence indicate that longevity matching saves a lot of graft life years and saves a lot of money. In the US, they have a longevity-based kidney allocation system. What they do is they transplant the best 20% of the donor kidneys to best 20% of the recipients, and the balance 80% to balance 80% of the recipients. And in Canada, they specifically allocate younger donor kidneys to younger recipients. However, at present, longevity matching is not part of the allocation algorithm for Australia. But there's a lot of talk going on and a lot of efforts being done to develop a similar longevity-based kidney allocation system for Australia. So hopefully in future, Australia will also have a longevity-based kidney allocation system. Then the third research question of the presentation. What could be the most cost-effective longevity-based kidney allocation system for Australia? For this, I compared the current Australian kidney allocation system with 4 longevity-based allocation options. To calculate this longevity-based allocation option, I had to assess the donor kidney quality and recipient quality. The donor kidney quality was assessed using kidney donor risk index. The recipient quality was assessed using estimated post-transplant survival score. And both these scores have been validated for Australia. So in option 1, best 20% of the donor kidneys are transplanted to best 20% of the recipients and balance 80% to balance 80% of the recipients. In option 2, lowest quality 20% is transplanted to lowest quality 20% of the recipients. In option 3, the youngest 25% transplanted to youngest 25% of the recipients. In option 4, oldest 25% of the donor kidneys transplanted to oldest 25% of the recipients. And for this analysis also, I used a Markov model which had 4 health states. The cost and the utility values were same as the previous analysis. Transition probabilities were calculated from the same data set, and time-dependent transition probabilities were calculated using Weibull regression method. Willingness to pay threshold, the perspective, and the probabilistic sensitivity analysis were same as the previous analysis. So here I calculated the incremental net monetary benefit, which means the net monetary benefit of an option minus the net monetary benefit of the current practice or the usual allocation system. So if the incremental net monetary benefit is a positive value, it indicates that the option is cost effective compared to the current practice. And if the incremental net monetary benefit is a negative value, it indicates that the option is not cost effective compared to the current practice. So I found that the option 2, which is transplanting the lowest quality 20% to the lowest quality 20% of the recipients, is the most cost-effective treatment method compared to the current practice. And the probability of error in this decision is around 24%. So in summary, transplanting the lowest quality 20% of donor kidneys to the lowest quality 20% of recipients was estimated to return the best value for money for the Australian health system. So finally, what are the key messages from this presentation? The first message would be there has been an upward trend in discard rates of low quality kidneys over the years, with the percentage around 65% since 2015. And one of the main reasons for this high discard rate is the short-term high costs associated with low-quality kidneys. Our study demonstrated that low-quality kidney transplants provide significant economic benefit to health systems, as well as improvement in patient quality of life in long run. Therefore, healthcare policymakers have an opportunity to nudge health systems further towards kidney transplantation through reducing the discard rates of low-quality kidneys and reimbursement mechanisms that neutralize the short-term financial disincentives inherent in transplanting low-quality kidneys. The message 2 would be appropriate allocation of deceased donor kidneys to potential recipients is an important aspect to consider in efficient use of donor kidneys. The current Australian kidney allocation system prioritizes transplants with few HLA mismatches, followed by allocation based on waiting time. And our study demonstrated that compared to the current kidney allocation method, transplanting the lowest quality kidneys to the lowest quality recipients could return the best value for money within the Australian health system. And combining these two messages together, it indicates that if the new Australian kidney allocation system can channel the low quality kidneys to older patients, older recipients, it will increase the usage of low quality kidneys, thus reducing their discard rates, and will also promote the best value for all donated kidneys. This presentation was based on 4 publications that I did during my PhD project. And the paper, which was published in Valuing Health, donor quality kidney and transplant outcomes and economic evaluation of contemporary practice, won the HusTrans 2020 Best PhD Paper Award. And I would like to acknowledge all my supervisors, Sanjeev Gularatna, Adrian Barnett, Nick Graves, Helen Healy, and Kesh Babulal, who gave me tremendous support during my PhD period. Thank you.
Excellent. Thank you very much, Sameera. That was a terrific presentation. Really, really interesting, really clear as well. Talking about not only your research questions, but the methods you use to answer them, and then some of the policy implications. So I'd now like to invite people to type in a question in the Q&A button on the bottom of your Zoom screen. And while people are doing that, Sameera, I've got a couple of questions to start off with. So the first one really is about the translation of your research and how you or others might discuss these findings with decision makers, particularly the TSANZ, which looks like it's the association that oversees allocation policies in Australia and New Zealand. So as a health economist and a researcher, do you or will you have a role in educating decision makers about the research findings? And how do you see what's the best way forward for translation?
Yes, that's a good question, Rachel. A question that most of the people ask me when I present this study. Well, I have been trying with my supervisors. I have 2 nephrologists in my supervisory panel to identify the best method to communicate this to the nephrologist or the decision makers. And I am just fresh from finishing the PhD, for hopefully in the future I'll talk with my supervisors and with the other stakeholders to devise a mechanism where I can communicate this to the relevant stakeholders.
Okay, terrific. There might be some people on the call who've got some thoughts on that as well that could be helpful.
Yeah.
So one question through the Q&A function. It's a comment around the messaging from your study. How do you sell the idea of giving low quality kidneys to low quality patients, especially from the patient's perspective? So is in terms of the terminology that you would choose to use?
Well, the best way would be, they have only two options: either to get a transplant or remaining on dialysis. And we know that dialysis is a method with high morbidity and mortality, and also very poor quality of life compared to getting a transplant. So I think if we can communicate this message to the patients, low quality patients means most of the patients will be old patients. So if we can communicate this to the patients, compared to remaining on dialysis, your quality of life would be much superior if you're going to go even a low quality kidney transplant. I think the patients would buy this, and will also help the health system as well. I think it's just a matter of communicating it correctly or communicating the right facts. So once it is done, I think they will undergo low quality kidney transplants.
Okay, yeah, I think that's an interesting question. So the next one is, do the dialysis costs used in your models capture the loss of income when undergoing dialysis? So if you could just touch on the perspective of your economic evaluations, and in particular whether you included productivity losses.
No, this study was done from the healthcare payer's perspective, and I know it's a limitation that I did not do the societal perspective, which includes both the patient perspective as well, which usually includes the lost productivity and lost income. So no, this study was done from the healthcare payer's perspective, and I plan to do this from the societal perspective. The limitation was I did not have enough costing data for patient level costing data to model this using a societal perspective.
Okay. And then a couple of questions, sort of specific ones, really more for clarification in your approach. I noticed, I think it was in research question 1, that your willingness to pay was $28,000. And I just wondered if that's $28,000 per quali gained, why you chose that level.
Yeah. I know that most of the Australian health economic studies use $50,000, but a recent study done in 2018 indicates that $28,000 is the most practical willingness to pay threshold, considering the resource constraints and also considering the opportunity cost. So we thought that it's better to use a WTP value which accounts for opportunity cost as well as the limited resources. So this study was done in 2018. So we thought that it's the best value that we should use.
Okay, I'd be interested to hear a little bit more about that. So that's I think a unique approach to take. So did you do sensitivity analyses then around using different thresholds? So if you did use 80 or 100,000, were your results still showing, for instance, that low quality was better than remaining waitlisted, and that low quality was better or worse than waiting for a higher quality kidney? Because if you're willing to pay more, that result may change.
Yeah, I did sensitivity analysis using 42,000, 50,000, and 67,000. And in all of these analyses, the results were the same.
Right, okay. Terrific. All right, we have some more questions on the Q&A. So small technical question, did HLA matching and time on waitlist factor into your modelling, or was it solely based on the KDPI versus EPTS?
Sorry, can you repeat the question again?
Sure. So this is about your, I guess, your criteria for a low quality kidney. Did the HLA matching plus time on the wait list factor into your modelling, or was it based on KDPI?
The quality disease on a kidney quality was solely based on the KDPI value, but in the model I factored in the time, the time that patients stay in waiting list also. This time was taken from the HENS data, so the different patients stay in different time periods before they get a kidney. So that time period was also factored in the Markov model.
Okay, and was that using a sort of a continuous variable for time, or was that based on the mean time of transplantation?
I categorized the time periods in less than 1 year, 1 to 3 years, 3 to 5 years. Likewise, it was categorized into 3 or 4 categories, the time period.
Right, okay. Okay, excellent, thank you. The next question here, there is also an opportunity to increase the number of living kidney donors. So not just deceased donors, but living kidney donors. Could your models be used for this scenario?
Yeah, definitely. But the transition probabilities and everything might change. But that would be interesting, which I have never thought of. But that's an interesting research question to find solutions in the future. The model should be the same, but the transition probabilities will have to change depending on the live donor transplant information.
Mm-hmm. Okay. Another question, this is something I've often wondered about, is from a health system perspective, is the costs, costs of healthcare use in these transplant models tend to start from the day of the transplant operation, and they don't consider the pre-transplant workup. I'm wondering whether in expanded criteria donors, whether the workup is different and whether it's appropriate to include not only the screening tests, but some of those corrective procedures that need to be done before somebody is then officially on the wait list. Is it something that you've looked at, and if so, or if not, do you think that would make a difference?
That's an interesting question, Rachel, which I have never thought of, but it would be interesting to see whether that would make this change, but I'm not really sure whether this will make a significant change, because the difference between marginal quality, low quality kidney transplant and remaining on waitlist, the difference was huge. So I don't think adding the other, the marginal quality workup cost will change the decision much. I don't think it will change, but that's an interesting thing to find.
Okay, great. Another couple of questions through on the Q&A. Are KDPI and EPTS used widely or are relevant in the Australian clinical practice?
Asking whether it's practiced widely, is it?
Yes, is KDPI and EPTS, is that the way that these kidneys are classified, I guess? Is that relevant in the Australian clinical practice?
I'm not a clinician, but according to the discussion I had with my clinical supervisors, it's widely used, yes. Okay. Both KDPI and EPTS.
Okay. And now we've got an update. This sounds like this might be somebody clinical, or certainly in the know on the line. TSANZ have released a change to Australian deceased donor kidney allocation effective in about a week's time, 4th of May, 2021.
That's good news.
Yes, including the concept of survival matching.
Oh, that's nice.
So, you know, whether you can claim this in the impact from your PhD research, that certainly sounds like really good news. So thank you to whoever's put that in. It's come in as an anonymous attendee. But I think Sameera will probably be very interested in making sure he's got a copy of that new application policy from the Transplant Association. All right. Sameera, is there anything else that you'd like to add or tell us about what you're going to do in your postdoc if you're continuing to do research in this area?
Yes, currently I'm working as a health economist at Australian Centre for Health Service Innovation at Queensland University of Technology. And my passion is research on chronic kidney disease, because when I was in Sri Lanka, when I was doing my MD in public health, my research was solely on chronic kidney disease. So that I wanted to continue here as well during my PhD. So I'm really interested in doing research on chronic kidney disease, or else other non-communicable diseases. So I'm happy to collaborate. I'm happy to get in touch with people so that we can build a good network and come up with some interesting research questions where we all can find solutions, so that ultimately the patients will benefit. So that's what we all want. It's not the papers, it's not the grants. It's ultimately we want people to have a better quality of life. So yeah, I would like to invite everyone who is someone is willing to collaborate and come up with research questions. I'm happy to join in.
Excellent. Okay, well, I know we do have Professor Angela Webster, who's on the webinar today, who's leading a project including epidemiologists and statisticians and health economists looking at these policies, and I'm sure would be very keen to get in touch with you. That's the MODUS project. Funded by NHMRC. And I see also there's a link to the new TSANZ kidney allocation documents, which I'll send through to you. And I think, Sameera, your contact details were in one of your slides. We'll make sure that when the uploading of this recording is on the HSRAN's website, that we have your contact details and can pass them along to attendees today. Terrific. We will now bring this to a close, but I'd like to thank you very much, Sameera, for a very thorough and informative presentation. Great to see your PhD work tackling these important problems, and looks like contemporary practice may change, so congratulations. Thanks. And thank you very much, everybody, to participating in the webinar today. Don't forget, abstracts for the HSRAN's conference close on the 6th of June, and we look forward to seeing you there, and also at the next webinar. Thanks very much.
Thanks.